Bobby will host a concierge that will be there to be, or a 24-hour staff will be there to direct you to where you need to be if a resident needs to go out. One of the things that we find is very important for our community is that we have 24-hour, 7 days a week nurses in the building. So they're licensed, they're assessing them prior to sending them out. So your call, you being called to the scene is going to be vital because of the fact that we are truly attending an emergency. You may have experienced in the past when assisted livings or senior livings, you're getting called and they may not be an emergency. Our nurses will assess them to make sure that it's true emergency. They'll be providing you with face sheets, which is the information on their medical needs, medications, any information that's vital for a hospital, including which hospital they prefer. Okay, so that will be a big part of this. We are obviously wanting to work with the community, so there are a number of seniors that we feel that are in need of these types of services. And what I truly feel is that we're more senior advocates than anything. We find that seniors in our communities are not receiving the best care or right care. They're in their homes or alone. You are going into their homes at times and responding to various situations. So if you're noticing a senior that may not be taking their meds correctly, may not be eating correctly, they're confused, one of the focuses for Maple Senior Living is truly focused on senior living and Alzheimer's and early stage dementia. So this is an environment that is secured in various areas. We have 3 tiers: assisted living, our TIDE program, which is a program that focuses on earlier stage dementia. And what that means is that they're still aware of many things that are going on, but have early stage memory loss. So their area is almost secured in the evening time. Okay? Our advanced memory care residents are the ones that are in the secure area 24 hours a day, 7 days a week. We focus a lot on emotionally based programming for them because it really depends on how their day is going matters.
Barbara was talking about our memory care and our memory care programs. Our straight assisted living is for those residents that have chosen a certain quality of life. Cognitively, they're doing pretty well. Most of them probably aren't driving, but they are functioning really well. They're active, they engage, etc. Our full memory care neighborhood, we call it, we try to get away from the clinical side of things at Maplewood, is a different story. And Maplewood prides itself on being able to take care of a cognitively challenged senior pretty much all the way through hospice. So you could get you will get a call, from that fully secured neighborhood with that dementia resident. And dementia, as you know, is a big umbrella supported by things like Alzheimer's, Parkinson's, Lewy body, etc. The big thing about those residents is, by definition, their brain is broken, but they've got big emotion. And so we just want to make sure that, to get into an ambulance is not a good place for them. It's very scary. They're confused. I mean, these are people that, if they walk outside sometimes it's difficult for them. They get very unnerved by any type of change. So we want to help you make that transition, as easy as we can. And depending on the situation, right? If it's a fall, that's different than a respiratory. And you guys are the experts, so you will know the pace of how that has to move along. But just so you know, they could be pretty far progressed in their dementia. The reason why we secure that particular floor is because of wander risk. We call it elopement, actually. First time I heard that, I'm like, wow, that's pretty cool. But we secure it so that they don't wander. And that means wander out of the building. We definitely encourage them to walk. We have an outdoor patio that's fully enclosed. Maplewood's all about natural light. We're all about, we have farm to table. We're all about good nutrition. But we secure their residents to make sure that, it's a self-contained neighborhood, we call it, where they dine and do activities. We do take them on excursions daily, so they're not in their residence or this floor all the time. But so that I think would probably be the biggest challenge, just because cognitively they're not at the same level as our straight assisted living.
Our average resident is about 85 years old. They usually have a need for at least 3 to 4 activities daily living, addressing the daily routine, escorts, transfers, medication reminders, toileting. Those are usually what we have. We have mostly females, because we outlive most men. Most of us are told that we could.
Sorry guys.
But that's what our demographics look like. We'll see people who have had strokes. And we will try and provide as much information to help you provide the hospital. The other thing we want to make sure is, again, we're partnering with the community. So if you are going out and you are seeing someone that may need some support and you're not sure, call us. We do home visits. We will go see a senior in their home and see what we can do to help them get the support they need. It doesn't necessarily mean that they're going to move into our community, but they may need something like a visiting nurse or physical therapy or occupational therapy. And we have those resources available to us.
Yeah, good point, a very good point by Barbara. I mean, we have a full-time Kristen Hocker. You guys may know Kristen. She lives here in town. She's supporting both communities, Darien and East Norwalk, and her, sole purpose at this point, along with Barbara and myself, is to get out and develop these professional relationships with, like Barbara mentioned, visiting nurses, geriatric care managers, elder care attorneys, what have you. So we've got a lot of professional referrals that we can refer should you come across somebody that, again, not to bring them into us, but even serve as a resource. I mean, that's really what our goal is to serve as, the primary kind of go-to for seniors in the community.
And some people may ask what the difference is versus Maplewood and other areas. We have a very good partnership with Atria and Darien. They're more of an independent community, and we are more advanced in serving needs of care. So that really is something that we are looking at, and always making sure that we are working hand in hand with them as well as with you. Our goal is obviously to take care of seniors. So what are you seeing that you can educate us about when you're responding to seniors? All our seniors are healthy? We had no calls to any seniors in the community.
And we too, you would think when Barbara talks about the difference between us, or one of the differences maybe between us and Atria Darien, independent living, you're still cooking. We don't have kitchens. We have kitchenettes. We provide meals. It's the activities of daily living, ADLs we call it. So like Barbara mentioned, grooming, bathing, toileting, whatever. But as far as mobility, that's a challenge for us too. We don't put bars all along the walls and all inside your apartment. Everybody has an individual apartment, by the way. They're 1-bedroom and studios. Sometimes a resident will want to kind of double up. Everybody has their own apartment, their own door. They all lock the door. We obviously have a master key to all the apartments, but they're not outfitted with bars everywhere. So we too are definitely challenged by falls, especially, kind of getting in and out of bed at night. So you can see that, even with us.
Even though we talk about a secure area, we want to make sure people understand we're focused on trying to maintain as much independence as possible. So they will be doing as much as they can to maintain that independence.
And since some geriatrics have different mental states, it's really helpful when their nurses can tell us what their normal mental state is. If they're usually they won't be able to tell you their name, or if this is different.
Yep, and that's a really good point, especially with, dementia as far as, being able to speak. Now, I think, and Robert can comment as well, we have a corporate director of memory care, Mary Underwood, who's amazing. We all have to go through training with Mary. It's 6 hours of training, whether you're the laundry guy or the salesperson, or, you never touch, a resident per se. We still have to go through that training. I would think that if Mary were up here, she would say, undoubtedly, somebody shows up with a stretcher or even a stethoscope, or we may not know what that person's, mental state will be at that time, as far as a dementia person, even a person in assisted living possibly, because their anxiety could certainly go up. But as I said before, I think with dementia residents, any change can be really disheartening for them. And we're experts at getting them to transition, like from their home into our community, or that's a great example, except when it's an acute situation that can all kind of go to, heck in a handbasket.
Yeah, I have a quick question. What's the average stay of one of your patients? So is it more of an end-of-life care, or is it in the long term?
Excellent question.
It will depend, it will vary. Our average length of stay is usually between 2 and 3 years. I have seen people in senior living for up to 9 years. Sometimes they just are lonely. Socialization is so important for seniors just because of the construction. People will move in, and that may be the biggest piece of why they come in. So they may be very cognitively able to interact and physically able to interact and do things. So it will vary.
I have a question about the different models or whatever. I'm just remembering back to the whole $5.99. Are they hospital rooms? Are these people's apartments? Are they furnishing them with their own furniture that they bring in, or do you have the model that makes it easy for someone to get in with a stretcher and get somebody out of trouble? Or are we going to be, are we going around grandma's dresser?
We're obviously going to focus on, when we're walking into the apartment with them, we want to make sure that they're arranging furniture that doesn't cause more fall risk.
Right.
But they are their own apartments. We have studios and 1-bedrooms. They do bring in their own furniture. That's part of the piece of helping it create a feeling of independence and a feeling of home. That they're still making those decisions for themselves. We usually work very well, and again, it's a new community for everybody, but in the 8 years that I've been with senior living, we work very well hand in hand. You're escorted from the door to the resident's room, especially since it's going to be a new community. We take you into the room, we clear what we can before you get there to make it easier for you to do your job.
Okay, good.
Right, and, excellent point. I think Ron, though, met with possibly even Tom Gaston up on the development front. The accessibility into the bathrooms are huge. I mean, everything is wheelchair accessible, to say the least. But they do have apartment doors. They are apartments. We call their residents, not patients. We try to get very far away from the technical term because we don't have skilled nursing. So and it's up to executive directors, but there's 5 Maplewoods, and at this point, we do not have residents on breathing tubes, feeding tubes, or Hoyer lifts. If we have somebody like that, we refer them, we refer them to a skilled nursing facility at that point. So we kind of draw the line there, but, you know, I talked to somebody today with cerebral palsy, wheelchair-bound residents are, I wouldn't say they're common in these two communities yet because nobody's aged in place. It's brand new, so our acuity level for our residents should be pretty low from assisted living. You know, East Norwalk, we've got 2 residents already that have deposited. They're 65, they have full dementia. But completely ambulatory, very fit, but yeah, 65. And just so you know, for all those kids out here that have grandparents that are, you know, well, not even yet, but 90 is kind of the target level that if there's no dementia by that time, you're 89, 90, you're in good shape. So it doesn't come on much after that. My mother's 89. I heard that stat. I ran out of the room and called her. I'm like, you're fine. So you should be able to maneuver well. Again, in our dementia residents, you know, we encourage bringing stuff. Not to the extent, though, that you wouldn't be able to have access, but, you know, stuff meaning more pictures, I think,
Right.
would apply. Yeah, we'll work with them on that for sure.
To go hand in hand with your question and this gentleman's question, we also work with outside agencies such as hospice. So this is their home and it's there at the end of their life. We will work with hospice. Hospice can work to get a mechanical lift in. So hospice can do that, but their staff needs to be trained and our staff needs to be trained specifically to do that. But it is rare because we're looking at the quality of life for the residents. All those questions. Go ahead.
So would you set funds as possible, would you set out a way for have hospice?
We do everything we can, that is appropriate and safe underneath our license, to keep them in their home as long as possible. So they may be on hospice and have a 24-hour private.
No problem. And so, yeah. It's just if they need skill, or they have chronic wounds, that we can't, you know, that kind of thing. Or as I said, you know, oxygen, prevalent for sure. Portable oxygen, hooked up in the room oxygen. But, you know, breathing tube, we try to have them be able to even feed themselves. Again, kind of borderline, but we try to get them to be able to sit with that.
How do the agents, do they come in and check on a regular basis and it's the same age every time the patient or switch on just like, from the standpoint of getting a medical history on the patient, especially when they're dementia, seeing what they're based on status and things like that? Are these aides if they're the same age every day and will the aide be there all the time?
We're obviously open 24/7, so we can't have the same person all the time. Our goal is absolutely to focus on the same staffing on the same floor as much as possible. So we will hire a full-time aide, and have them 7 to 3 for 5 days a week. Obviously, their off days, we will have something else.
Yeah, so it's a shift, right? 7 to 3, 3 to 11, 11 to 7. During the day hours, there is a director of nursing in all of our communities. In the state of Connecticut, we call it a SALSA, Supervisor of Assisted Living Services Agency. I know, it's a dancer. So the SALSA will be there during the day, but you know, her job really is to just manage the LPNs and RNs and the aides. But as far as the history, we should be able to have no problem getting, you know, their record.
I just have a question. What's your policy on identifying a patient with MRSA? And how would we know when we approached if that was present?
A nurse will always go out and assess a resident prior to them coming in, and every time they go out, they will be assessed prior. So if they have to go to a hospital or a rehab, they will be assessed. We need to get medical history from the physician prior to having them move in. So whatever information we're getting, and we will obviously share that. If somebody has MRSA, we we will usually not allow them to come in until we have a little bit more clarification on what the stages are and whatnot. I think it's, you probably know this better than I do, it's in your body once you have it, is that accurate?
I believe so, but usually they put something on the door so people know to take appropriate precautions.
Right, and if there's somebody that has MRSA, it's very rare in assisted living because we are precautionary, because of the community living aspect. We usually will not have them come in if it's something that is predominant.
Your brochure talks about medical staff, like a medical doctor or somebody that's going to be there. What is the interaction with him, let's say cardiac arrest or something like that? And will the MD that's in residence go up to the floor, or they just kind of hang out in his office?
We are affiliated with New England Medical Associates, and there is one director that oversees all of our communities. We have 5 communities. He won't be based necessarily every day, but because of that, that's where our 24 hours of daily licensed nurses play a vital role. The nice piece of having a physician involved directly with our residents is, especially with memory care residents, it's so much more difficult to take them out of their environment, so much more difficult for a family to take them and schedule that appointment and get them to the doctor's office. If we're having those people that are beginning stages, sometimes the resident won't remember everything a doctor says, or some of our seniors don't share as much information with their families. So our doctor will be able to, and our nurses will be able to provide direct information to the family if there are concerns.
But not on site, 24/7, 365 in one building, kind of shared amongst the group.
Right, but if the doctor is in residence and there's a cardiac arrest or something of that nature, will the doctor just kind of stay in his office and let us kind of handle it, or would we be expected to, would we like to see him or her on, in the patient's room?
Most likely, they're going to respond before you get there
They will,
and be
okay.
able to communicate.
And in terms of security on that high security floor, sometimes not all the ambulance crew comes up at the same time, or the adult responds may not get there at the same time. So we need a way in and out, or somebody's got to be watching for, there's people that forgot to bring up and somebody goes back down. So just be mindful of that, I guess. I don't know what else.
Excellent point. The security is a code, and we'll make sure that, we have enough staff. Obviously, if there's an emergency coming in, we'll make sure that
Is there
there's
always somebody staff in the building at a desk by the door?
There will be staffing in the building 24 hours a day, 7 days a week. Our staffing structure, we're still trying to work out.
I would maybe suggest that you have a call, you dedicate somebody to that secure door, break this wall.
I
So
agree.
that we can.
Yeah.
You don't want us running around with codes.
This
Although
is
the
exactly our
Stanford
style
people
of
do those
post.
stuff. How many residents do you have?
And at Darien, we have 66 apartments. So it'll vary because obviously we do have quite a bit of interest from couples. So if they decide to do a 1-bedroom.
I was going to clarify before, at Lily's point, we're used to going into rooms where patients have hired aides, and I don't know, that's something that exists here at Vineyard, because they each have their own personal aides.
Assisted living, families have the opportunity to go with private aid. We can't take that away.
Right, so that person will be a consistent voice for that patient when we get there.
Yes.
Yeah, I don't know about, I don't know, Barbara, with your residents thus far. In Strawberry Hill, we're about 25% occupied at this time. Most of it is our straight assisted living, and I'd say for that portion of our community at 25% full, we're not hearing of a lot of aides at this point. Each of our levels of assisted living, straight assisted living on through full memory care, we, along with their rental fee, they get a certain amount of time of personal one-on-one care. So, you may not, again, initially you may not see a lot, but as the residents age in place, I'm sure that'll change.
I was just wondering, is there a service elevator that's big enough to push up there?
There will be two elevators. So So it's usually, you're probably utilizing the staff one,
Okay.
because we'll make sure that that one is accessible for you.
Okay.
And they're right next to each other.
So, very often our care involves sort of assessing the mental status of the patient, and the paramedics will want to know what changed, why did you call 911? So given all the mental patient in the first place, it's important to understand the baseline a little bit. So just, I think you should be ready for those type of questions.
Okay.
So you have transient care to make that very difficult, right? So, I think you'll probably see us doing that. The other thing is, if you have a patient who's got some form of anxiety where, if somebody were to give them more of an aggressive, like an IV or a finger stick for glucose, we should know that. That should be on the sheet. We don't want a patient to suddenly get violent, right? So those things.
And can you just kind of touch on, when you say baseline, cognitive baseline, what kind of things would you like to hear about then? Just,
It's very simple. If one of us came on a call and somebody says to me, she's acting differently today, I would want to know why. How do you see that? Because we're going to have to, we have to give the information to the doctor. The doctor sees somebody who, says, 27 times I ate chicken for breakfast. How is that different than, the day before where they said they had, chocolate cake for breakfast, right? So, we need to know if there's a real, if there's a change, if it's something that how it was picked up, how's the patient presenting differently today, what happened. Strokes would probably do something. One other thing is we do blood pressures, we do those in-house, but if you were interested, you could probably do community sort of blood pressure screening, at your place, at some regular interval. And just get your residents, obviously not the, top floor, but
It's the second floor. Our 24-hour secured area is the second.
we're good for 1:30.
Except between 7 PM and 9 AM because they,
No, we'll be in the lobby and you send them.
I told you that's why we're gonna personally escort.
yeah, we
And
do
one
have,
of the things that I just wanna touch on, I'm sorry, is I want you to be a little bit, cautious because you have to remember these residents are gonna be new to us to begin with. So we may not be able to provide as much information as you like from the get-go, but, whatever we have, we will definitely share with you. And one of the things we definitely see with dementia and residents that have Alzheimer's is, any type of huge transition can be traumatic. So you may be called because of the fact that they just moved in that day and something happens.
Other things to be aware of, if the patient's going to be upset with lights and sirens, and it's a serious call, you might want to request a silent approach. Our first responders in the town are the police, so you should be ready to have at least one police officer, usually 2 cars, 2 police officers come as well. So I would say that's just a good.
and then Ron, where will they, so we have this horseshoe.
I don't know where they'll park. They'll probably
Okay,
park.
they're not gonna
in front.
Park in the
They won't
front.
Right on the
No,
street.
they'll do the best they can.
Yeah.
They get,
Give you the-
we get
this
1,500
one.
calls a year. They probably have, 10,000 calls a year. So, they know where their car is. But we should be ready to have officers running around in their place as well, not just,
Sorry, I know at other, assisted living facilities, they have, right, when you walk in, like a face sheet that summarizes their care. Should we expect to see that, or should we rely on the nurses for their information?
It will depend on who we're gonna be providing that, and maybe the nurse versus the CNA or the concierge, but you will definitely get that. We're trying to figure out everything that works best. I personally think, and I've found in my experience, a nurse handing it to you is better because she's gonna give you their history as well. She's gonna be talking to you about it. Concierge probably is just gonna give you a piece of paper, and if you have any questions, you may not have those answers.
The other thing, just to quickly touch on, is, Barb talked about a portion of the building being secured at night. Those residents during the day assimilate, matriculate, whatever word we wanna use, with our regular assisted living, and, you know, if they're all in the dining room, you couldn't tell who at night was in a secure environment, just because they wake up in the night and they start getting confused, or they need a little bit of cueing about what time yoga is, or, so we will make sure, we know who those residents are. You obviously won't, but we'll make sure that you know that they kind of have the beginning of onset dementia, because to all of us, myself included, when I go to one of our other 3 existing communities, you know, nobody's wearing a badge that says, hi, I'm Leslie, you know, I live in Tides, we call it Tides, you know, 218, so we'll make sure that you know that. And I think at the beginning, we're really gonna take a lot of history from the family. We meet with our staff daily to talk about, you know, to go over the records daily on the floor. So, you know, we should have a good idea about what's going on, or if there was any change, or really should be pretty current. I think especially at the onset, we'll be pretty on top of it. Yes.
When is your facility open?
We're both slated in Norwalk and Darien to open November 1st. One of the things that we hope to do is try and get you all to come and visit us, so we can tour the building together. If there's any other questions or anything
That would probably, right, that would probably be pretty beneficial. And I think we're, you know, also as far as numbers, we're hoping to be at about 50% by November 1st. I would say, since Greg Smith, the CEO, is not here, that's, you know, that's a bit of a stretch, but that's where so that'd be 33 in Darien. Not to all move in on day 1, by the way, so we're gonna kind of filter that in depending on, now, of course, if it was significantly less than that, we would probably, and we will be overstaffed for sure initially. The ratio of staff to residents initially will be pretty low.
For emergency personnel, yeah.
Maybe that's for, yeah. Actually, there's a loop and then there's also turns, right?
There's a loop that will go back out or down to the garage.
So we could also, if there's extra cars, you could go along the garage ramp, right?
Yeah.
That's where the police
Like-
probably go.
Yeah.
You can tell them, we can tell them how.
I was gonna say, because they're gonna have, but the horseshoe really is gonna work out much better. Yeah, go ahead.
We have this training, you know, every Wednesday night, and you were talking about someone there who's an expert and does training. If you have somebody who has some kind of expert training on
Yep.
Alzheimer's and early dementia, Marilyn right here is the director of training, but maybe there's a way you could share that at some point. with us
Terrific.
on Wednesday
We
night.
can absolutely get Mary Underwood here. She would love it. She's great. You know, that's what she does for the communities. And she actually, when she's not training us, she works every day at a different site. She has a mobile office. Her background is, she's a social worker. She's been working with dementia residents for 25 years, and she's just really superb. So let's get her in here. That'll be fun. She'll love it.
How do they activate 911? They dial it themselves, they have an alarm, they call the front desk.
They will all have a lifeline alert system that goes to our team. Our team will be contacting you. They
So-
will have full access to phones, so they will be able to.
Probably it needs to be clear from your side how that 911 is activated. From our side, the calls go to a medical dispatcher at CNET, which is EMP services. In your case, the person who's, if it's a alarm button and it goes to the front desk, the person at the front desk won't be able to give too much information, right?
That won't trigger 911.
Okay.
The lifeline will trigger our
I guess you
staff
guys
to go to
go
that
to-
room and assess and determine what they need.
So those are they're gonna ask some very pertinent questions to determine the level of response that we need to. So that's fine. But you might want to just differentiate those, call 911 from, at least know, how do you know that there's a call coming if I dial 911 from my apartment?
That's gonna be interesting to us. I'm gonna be honest with you.
Good luck.
Yeah. That's where we call the family and say, wait, maybe time to take a phone out of the apartment.
Although in our existing communities, the 911 calls are down 78%, so. Is that different? You got a call in Norwalk or in Darien?
By the way, the bathroom in the we did take a tour of the Norwalk facility. The bathrooms we saw were very big, which was very helpful. Making those
Similar
bathrooms.
size in Darien, and they're all, I think I can speak for Darien too, all of ours in East Norwalk are all the same size. So it's not like, the apartments that are outfitted with your own stuff. There's a little bit of a construction difference. I think you have more customization nooks and crannies than we do. We're pretty rectangular. High ceilings though, the buildings were gutted, so, they're 10-foot ceilings. Carpet, I don't know if you need to know that, but everything's carpeted. It's not Darien. You've got some, in case you want to open up a branch in East Norwalk for me.
There will be, the garage goes downstairs, or the driveway, I should say, goes down to the garage. There will be a lobby in the garage, that people can access the elevator.
If there's like a call or wall, there's something down there, like, many people that I don't know, that should probably find it out, which is
That's a great point, because God forbid somebody does fall in the garage, we will make sure to make a note when we're calling you to say, please move back straight down to the bottom.
The ambulance won't fit.
Our ambulances are 9 feet. We like them.
Other questions? Anything else we can do to work with you? We thank you so much for your